So the goal of this research was to determine the absolute incidence of denial of DAA treatments by type of insurance and to determine the specific factors associated with denial. The background of this is that as new direct-acting antivirals have been released into the market, these drugs unfortunately are very costly, and due to the high cost and anticipated demands of these drugs, many insurers have subsequently placed restrictions on their use. Many insurers require that clinicians and collaborating pharmacies complete requests for prior authorization, requiring documentation for their patients to have met specific needs, such as evidence of advanced hepatic fibrosis or cirrhosis, prescription by a pharmacist. Some of the insurers have even required abstinence from drug or alcohol. And these restrictions have been very highly discussed over the summer, particularly related to the state-run Medicaid programs. So, and these restrictions have led to denials in receipt of antiviral therapy and delays in treatment. But to date, there have actually been very few data evaluating the incidence and the determinants of absolute denial in clinical practice settings. So that was really the basis for studying these denials. We defined absolute denial as a lack of fill of the DAA due to no approval by the insurer, even after appeal. And we studied patients who had their prescriptions submitted to Berman Specialty Pharmacy, which is one of the top hepatitis C pharmacies across 4 U.S. states: Delaware, Maryland, New Jersey, and Pennsylvania. And what we found was that among 2,321 patients who had prescriptions submitted to the pharmacy between November 2014 and April 2015, overall 16% of the patients were absolutely denied direct-acting antiviral treatment. But more interestingly, when we actually evaluated by the type of insurance classified as either Medicaid, Medicare, or commercial insurance, patients covered by Medicaid, 46% of those individuals were absolutely denied direct-acting antiviral treatment, compared to 5% of those with U.S. Medicare and 10% of patients with commercial insurance. And when we performed a multivariable analysis to actually identify the factors associated with absolute denial, U.S. Medicaid coverage and absence of cirrhosis were the strongest factors associated with absolute denial. We evaluated the median time to fill among those who actually obtained the fill by insurance status. And patients who were covered by Medicaid had significantly longer times to fill, 24 days versus 14 days for Medicare and commercial insurance. But when we then stratified by those who had any denial, but subsequently had insurer approval leading to fill, across all the insurances, the times to fill were higher, but significantly higher for Medicaid patients, 46 days to fill, compared to 35 days for Medicare, 32 days for commercial insurance. What we concluded from this study was that 16% of patients had absolute denial due to denial of their DAA treatment during the observation period. But most notably, almost half of the Medicaid patients were absolutely denied treatment, and those individuals had a longer time to fill. It's incredibly awkward as a clinician to have to go into a patient's room after they have been denied and to try to rationalize that denial. From a patient standpoint, I think that the so overall the implications of these denials really are unclear. But I think they very well may have adverse downstream outcomes on patients and providers. So from a patient standpoint, the inability to treat and potentially cure somebody could lead to continued progression of their liver disease and increase their risk of end-stage liver disease and liver cancer. If you wait until patients are advanced hepatic fibrosis or cirrhosis to treat these patients, then you still have to spend all of the resources to continue to follow them for hepatocellular carcinoma. Failure to treat these patients is a failure to potentially reduce the risk of HCV transmission. And if you consider the paradigm of chronic hepatitis C as a systemic inflammatory infection, then you continually put these patients at risk for extrahepatic complications, such as kidney, bone, cardiovascular, neuropsychiatric disease. And then from the psychosocial standpoint, the stress and anxiety of patients not knowing that they're unsure of how their disease is going to progress because of failure to treatment, I think is going to lead to the potential for suspicion and distrust of the healthcare system. And then from the provider standpoint, you lose that precious opportunity to link that patient into care, educate them about the disease, and potentially cure their infection. And that opportunity may be irrevocably lost. So I think that in answer to your question, it's very, very challenging for us at this point.